Hello, today we will be going through the axilla and the structures that go through it and make it up. So the axilla is surrounded by adipose tissue. The base is the skin and the subcutaneous tissue, and then the deep fascia. The apex will be the first rib and the superior scapula. In the posteriorly, and then the clavicle anteriorly. It's also bounded by the pectoralis major and then the deltoid. The anterior wall will hold the lateral pectoral nerve. It's also formed by the pectoralis major and minor. So here's the medial pectoral nerves. Here's the cephalic vein that will go through it. Here is the deltoid, acromion. Here's the clavicle. These are the cords of the brachial plexus. And this is going to be the pectoralis major. It's cut. And then the pectoralis minor would be like underneath, right? Okay, so the posterior wall is made out of the subscapularis, the teres majors, and the latissimus dorsi. And beneath all of that, there are the structures that form the foramen trilaterum. And the foramen trilaterum is also known as the triangular space. And I'm sorry, it's called the triangular. No, it is the triangle space. Sorry. This one will carry the circumflex scapula artery or the arteria circumflexa scapula. It's just called differently in different books. It's bounded by the long head of the triceps, the teres minor, and the teres major. And then the foramen quadrilaterum, or the quadrangular space, that's going to transmit the axillary nerve, the posterior circumflex humeral artery, and it's going to be bound by the surgical neck of the humerus, the teres minor, and the long head of the triceps brachii. Okay, so now the triangular interval is bounded by the subscapularis anteriorly, and then the teres major posteriorly, and it's going to transmit the radial nerve along with the profunda brachii vessels. So here it is. It's quite small. Here's the teres major. Here's the this is going to be the long head of the triceps, and here's the deltoid. The medial wall is composed of the upper 4th, 5th ribs and the intercostal spaces, and that's covered by the serratus anterior. Remember that the serratus anterior fixes the ribs and helps with like respiration. The lateral wall is going to be formed by the arms, of course. It's going to be formed by the coracobrachialis and the biceps. Here's this is like a superior looking down into the axillary space. So this is going to be in the front of the body anteriorly. This is going to be the pectoralis major, minor, medially. It's going to be the serratus anterior and the thoracic wall. Posteriorly, here's the subscapularis, teres majors, lat, and right here would be the scapula. And then laterally, it's going to be the intertrabecular sulcus, which is the humerus. Okay, so hydrogenitis is a condition where there's inflammation of the sweat glands characterized by recurrent nodules and abscesses. This is much more serious than something like contact dermatitis. It can occur in other places, in particular the groin, usually where the skin rubs together. And unfortunately, this leads to lesions that can progress to sinus tracts and fistula when it heals, and that can cause scarring and fibrosis. Here it is. This is quite prominent here, the fistula and the sinus tracts. Here are the active nodules. And this is unfortunately a chronic condition, but it goes away with age. It first appears when the patient hits puberty. That's when the apocrine glands start being active, and then it goes away around the time of menopause. So it can be caused by several infections like staph, strep, and E. coli, and it's treated with warm compresses, NSAIDs for the pain. It's a very painful condition. Antibiotics to treat the bacteria, corticosteroids to reduce the inflammation, and retinoids in order to increase with like the cell turnover and for new skin to form. The contents of the axilla include the axillary artery and branches of that artery, the axillary veins and those tributary. Also contains the lymphatics and the nodes, the nerves, which are the brachial plexus, and it is also like all contained in fat. So here it is, humerus. Here is the ribs, and you will see the axillary sheath that will contain the axillary artery, vein, and the brachial plexus. The axillary lymph nodes will surround it, and these are the tendons. There's a lot of lymph nodes in the chest area, especially in the axillary region. So the anterior pectoral group will drain the lateral quadrants of the breast, the superficial vessels from the anterolateral abdominal wall above the umbilicus, and the posterior or the subscapularis group will drain the back all the way down to like the iliac crest, and then the lateral groups will drain the upper limbs. So remember when we were going through the lecture about the chest that any metastasis of the breast can infiltrate into these lymph nodes and then metastasize all over the body, because look how many are connected. So the central group will drain the anterior, posterior, and lateral group, and it works as secondary filtration. Here are the central. The lateral lymph nodes are also known as the humeral lymph nodes. Sorry, I should have mentioned that. But this works as a secondary filtration station. And then the apical group will drain from all of the nodes, and it lies on the first rib, and it also works like as a tertiary filtration center. And then the infraclavicular group will drain the lateral sides of the hand, the forearm, and the arm. So it all comes from the humeral or the lateral lymph nodes. Okay, so the apical nodes will drain into the subclavian lymph node, and then it's different per side of the body. The right nodes will drain the upper limb and the back, and it goes right into like the right subclavian vein, while the left will drain the lower limbs along with the back, the thorax, the upper limb, right into the this will drain into the left. I'm not sure why I wrote down right. It really should be left. It will drain into the left subclavian vein. Okay, so there's several infections that we should pay attention to. So lymphadenitis is the inflammation of the lymph nodes. The humeral nodes are usually the first to be involved, and remember the humeral is from the arm. But they are characterized by something like nodule like that. Like this is quite a swelling for a group of lymph nodes. And the infections make the individual nodes palpable. Metastases of malignancies will make them feel indistinguishable. So that can give you, the clinician, a sign that, hey, this might be an infection or this might be cancer. Lymphedema is painless chronic inflammation of the lymphatics of the lower limb, in particular, only the lower limb. And this one, unlike lymphadenitis and lymphangitis, you don't treat with any medicine really. You use compression hose and advise the patient to elevate their legs whenever they are sitting, and to invest in something called like a pneumatic compression device, where the device will continuously squeeze and massage the fluid back into the legs, or back into the vessel, so it can drain into the left subclavian vein. Okay, so of all of these, lymphangitis is the most dangerous because it is the inflammation of the lymph itself. And it's dangerous because the infected lymph can go into the venous blood and cause sepsis. Unlike lymphadenitis, this doesn't involve like the nodes being inflamed. You can follow the tracks of the infection itself. Like, look, this is very serious. This is where the infection has entered. Remember when we were studying like the hands area? This is the where, like, the like ulnar veins would be, and it all connects into, like, the wrist, and then that can travel, as you can see, up the arm. So as a clinician, if you see this, immediately start the patient on antibiotics. This is like very serious, and because septic shock can occur very fast. It can it can take a couple days, or it can take a couple hours, and the patient, once they are in septic shock, it is very, very, very serious. So before even testing what kind of bacterium is causing the infection, it is advised just to start them on a broad spectrum antibiotic IV. Okay, so the nerves of the brachial plexus provide sensation to the skin and the deep structures. It's also a motor innervation, so this is considered like a somatic plexus. The sympathetic vasomotor nerves will also influence the diameter of the blood vessels, so that will and play a role in like blood pressure. And the sympathetic secretomotor supply will go to the sweat gland. And the roots of the brachial plexus derive from the primary rami C5 through 8, along with T1, and they make the three trunks. So as you can see here, the C5 will make these two like branches, the dorsal scapular and the suprascapular, and these are the only branches that go directly into the nerves itself. So this is like a direct nerve. The rest go into branches before going into the nerves itself. So the divisions after the trunks, they will split into the anterior, posterior divisions, and then they will recombine into the cords, and then from there it will branch off into the infraclavicular branches. And the cords lie in relation to the axillary artery, so the posterior cord will lie behind the second part of the artery, and then the medial cord will pass behind the artery. So all of these are going to be in relationship to the shoulder. So the nerves will be in the neck. The trunks will be right under the clavicle. The divisions will be right around like the clavicular area as well, and the cords, importantly, go into the axillary region, and then the branches go past that. So, like I said, the roots lie in the interscalene space in the neck. The trunks will pass through the posterior triangle of the neck, and then the divisions will lie behind the clavicle. The cords will be in the axilla, and the lateral cord will continue as the musculocutaneous nerve. The medial will be continuous as the ulnar nerve, and the posterior cord will branch off into the radial and the axillary nerves. Okay, so at the supraclavicular part, the branches will arise from the roots and the trunks of the plexus, and this can be approached for a block through the neck. Right here, it's going through the scalenes. It can also go through like the supraclavicular area. Infraclaviculars are a little bit rarer, and because like the branches will arise from the cords right around this area, so you do want to block it, but it's a little bit easier to approach the axillary when they all start to like condense again, and it's easier to approach through the armpit. Okay, so thoracic outlet syndrome is a group of disorders that compress the vessels and the nerves in the thoracic outlet right in your neck. It's between the first rib and the clavicle, and this is a rare, generally congenital syndrome. And the pressure of the lower trunk of the brachial plexus will cause pain down the medial side of the forearm and hand. If the impingement is particularly bad, it can also cause like paralysis. So it causes the intrinsic muscle wasting over time. There's like the circulation is compromised, and the only true cure is to surgically remove the first rib, but sometimes it's just managed with physical therapy and some pain relievers. Okay, so that's it for now. Thank you for your attention and good luck studying.